all the people who are joining us in webinar number 171 in the Andean Health Organization, IPOLI to NANE agreement, started a cycle of webinars in May 2020. The COVID-19 pandemic also teaches that the capacities built and strength in these 3 years should not be rolled back, and health should continue to be at the center of policies, research, epidemiological and genomic surveillance, the development of vaccines and drugs, and the deployment of health promotion and prevention measures are essential for a caring society. The pandemic also teaches us to maintain the human resource in health as a fundamental pillar of the health system, as well as to guarantee working conditions to contribute to a dignified life. Reflections on these and other priorities relevant to health and well-being can be found in the NotiSalud Andina newsletter monthly edition, available on the website of the Andean Health Organization. We invite you to leave your name, organization, and country in the comment box of the Facebook or YouTube live chat. In the same space, you can leave your questions or send them via email to webinarhorasconu@gmail.com. To access the certificate of attendance, you will find in the Facebook or live chats a fixed link. Please fill out the short survey and leave your email. Please verify that your email is spelled correctly for sending the certificate, which will be sent in the coming days to your email. In this webinar, we will follow the usual dynamics. We will start with institutional greetings, then the presentations of our speakers, to finally move to the space for Q&A. So at the beginning of this important day, I give the floor to Dr. Marisela Malki, Executive Secretary of the Andean Health Organization, who will give the welcome and institutional greeting. Go ahead, Dr. Malki. Thank you, Yadira. Good morning, good afternoon, good evening to all the people who are joining us in this webinar number 171, dedicated to health and safety of workers. Work is a human right. Universal Declaration of Human Rights of 1948 states that everyone has a right to work, to free choice of employment, to just and favorable conditions of work, and to protection against unemployment. Everyone, without any discrimination whatsoever, has a right to equal pay for equal work. And everyone who works has a right to a fair and favorable remuneration, ensuring for himself and his family an existence worthy of human dignity. Since 1973, the Orasconu has been working in a coordinated manner of the line of human resources in health. Remember that every April 28th, we celebrate the World Day for Safety and Health at Work, a date that invites us to reflect on the importance of ensuring a safe and healthy working environment for all workers, especially for those who are dedicated to caring for the health of others. Health must be at the center of all public policies prioritizing mental health. A safe and healthy working environment will not only benefit healthcare workers, but also patients, healthcare organizations, and the socio-economic development of the country. To achieve this, it is necessary to establish a culture of prevention based on social dialogue, participation, training, formation, and continuous improvement. According to the Ibero-American Social Security Organization, in 2050, the number of elderly people in the region will fall, and we will have to be prepared for this situation. From now on, recognizing social protection and security throughout the life course. Also, the ecological transition, climate change, that has to do with the health of the planet and people. And this is interrelated. And also the digital transition that is imposing us on all of us, especially in the management of social security challenges to be met. The International Labor Organization highlights that the gender gap in the labor market in Latin America has been affected by high informality and overloaded by care tasks caused by the pandemic of COVID-19. We know that 4 million Latin American women do not return to their workplaces. The overall rate of women's participation in the labor market has fallen to 46%, and they have suffered the rigors of informality and unemployment. Today's topic is crucial for the future of our healthcare system, the labor market for healthcare professionals and technicians. We will address this relevant issue with our panelists, Dr. Fernando Benavides and Dr. Pascal Dern. We know that there are many challenges we face in this area, such as shortage and surplus of staff, and even geographical distribution and suboptimal performance. To address these problems, we need effective policies that are based on a thorough understanding of characteristics and behaviors of healthcare workers. Thus, the welfare state impacts the attraction and retention of health workers, extending to the complex web of conditions generated by national and international contexts. Only in this way we can guarantee a practice that contributes to the sustainability of the welfare state of our human resources. On this day, I would like to acknowledge and thank the effort, commitment, and dedication of all health sector workers who every day put their own health at risk to save lives and protect public health. Their work is indispensable and admirable and deserves all our respect and support. Welcome to this webinar. Thank you. Thank you very much, dear Dr. Malki. Now, I give the floor to Dr. Hernan Sepúlveda, Regional Advisor for Human Resources for Health, who will give us the institutional greeting on behalf of the PAHOS Sub-Regional Program for South America. Go ahead, Hernan. Thank you very much, Yadira, and the Andean Health Association for the possibility of providing a thing on this webinar on the topic of human resources. Today, we talk about safety of health workers who have a specific role in the they're precisely the ones who provide care for others. I would like a couple of messages occupational health that has special characteristics. In the occupational health, Dr. Fernando Benavides is going to talk more about, and we consider it as a physical, mental, and social well-being of workers, and it covers prevention, risk control, and also the adaptation to work, how do that the workspaces are adequate for the functions that they're programmed for. And in the case of health, there are important risks that have to do with the performance of such as infections or being subject to harmful products, burnout, and violence, which are elements that are also important in terms of occupational health. Another conversation that we have on this topic, we always have talked that workers' health and mental health has not been a topic that has been on the agendas, on the regional and sub-regional agendas until the pandemic came. And the pandemic also showed us special concern on the health of health workers, because it was precisely the most affected by the health crisis. And those who had to respond to this crisis were the most affected, and that represented many challenges. You know, we did a study on how the health personnel was affected by the pandemic from the point of view of the physical and mental health as well. And I will say that this is an important learning and has allowed us to put in the agenda a key topic. Just to give you a few examples, the personal protection equipment was a major problem, and it was difficult to demand workers the commitment if the government or the institutions who provide the care didn't give them access to this type of PPE that could prevent and protect their health. Vaccination was also key. Fortunately, most of the countries, almost all the countries, gave priority to the health personnel for vaccination. Mental health resurfaced, reemerged. There was a great pressure on the health personnel working at the risk condition without seeing their family. And they have, in many countries, had to establish mental health policies directed to health workers in the hospitals. We also made the decision to add to this new disease as an occupational disease, and also they proposed the life insurance topic Marisela mentioned, made possible the improve the adherence of health workers to the health facilities because they felt protected. A topic that has been present in this institution has been mental health, which is a topic that has to do with health security in a dialogue with all the countries that participated. We identified 5 key topics to move ahead in public policy development. What we decided to do, because the pandemic affected how these measures taken in a context of emergency can become public policies. And we found topics such as staff distribution, human resource planning, training, adequate training. Something key was mental health, which is something that we believe that should be now permanently on the agenda, because the mental health of health workers, together with the working conditions, are not only something that affects the health staff during emergencies, but also during their whole development of their functions. We need to add this topic and take other topics that have to do with regards to the risk and exposure, infections, and products that where they work in laboratories, etc. So I think that this topic has been put again in the agenda, and it's important it remains there. And at least we from the Sub-Regional Program for South America from PAHO and the Andean Health Organization are working. So congratulations for this seminar. And we continue working with the Andean Health Organization. Thank you very much. Thank you, dear Hernan. After the greetings, I'm introduce myself. I'm Yadira Salas. I'm responsible of the Andean Committee for Human Resources in Health of the Andean Health Organization, and I will be in charge of moderating this webinar. After this preamble, and to talk about the welfare state and public health, the role of occupational health, we welcome Dr. Fernando Benavides. Dr. Benavides has a degree in medicine from the University of Seville and a PhD from the University of Alicante with extraordinary award. Since 2007, he is professor of the Department of Medicine and Life Sciences, MELIS, at the Pompeu Fabra University, and since 2010, associate professor of the University of Texas School of Public Health. His research aims to contribute to improving the health of workers through etiological and evaluation studies in occupational health, which help to inform priorities in occupational health policies. Since its founding in 2009, and until 2015, he has chaired the Center for Research of Occupational Health, CISAL, at Pompeu Fabra University, where he continues as a senior researcher. Dear doctor, welcome. You have the floor. Good morning, good afternoon from Barcelona, Spain. Thank you to the Andean Health Organization for this opportunity, and I fully agree with the words that have preceded my intervention to highlight the importance that health workers as an essential element in maintaining social cohesion. That is what the well-being state pursues, to have sustainable societies and are respectful with the environment. My intervention this afternoon is focused to some sites and reflections that we have from our center, the Center for Research in Occupational Health at the Pompeu University, but in a more conceptual manner. Now, without listening to Dr. Sepúlveda, I told us some ideas and some data we could have shared to support these comments from Dr. Malki, in the sense of celebrating the World Day of Workers in the scope of health services. But what I have prepared is this reflection on public health and well-being and the role of labor health. But during the Q&A, maybe we can talk other topics. If I have more time, I'm going to use my 20 minutes that are planned. I will focus during my presentation this reflection that is more theoretical.
Doctor Fernando todavía no ha compartido sus slides.
Sí, estoy en ello. Esto, aunque es rápido internet, pero
although the internet is fast, but it's not that fast.
Muy bien.
Okay.
Bueno, también además del
In addition to working in the Research Center of Labor Health, I'm the scientific director of the Ibero-American Observatory of Work Safety and Health that Yadira mentioned in my CV. I didn't share that detail of the Ibero-American Observatory. Perhaps the maps are so useful, it helps us in understand the reality living. And I think that this map helps us understand that everything is upside down. What we see, the center and the Pacific is in another place. So the Andean region is well located, at least geographically speaking, facing the new challenges of this 21st century, that we are having come out of a pandemic that has affected everyone and that have connected everyone. That's because these webinars started during the pandemic as a response to the emergency of the use of internet for these type of activities. I'm here and I'm going to activate. We are here in Eurasia Peninsula, and you are here in Lima, that's representing and working on this Andean area. We're quite far apart. We are in the periphery and look into the Pacific to see what our colleagues from the Andean region tell us. This is the model that I start for my comment, the health social determinant model that has a macro levels with a genetic burden that we are all born, conditions, as well as the sexual and characteristics and physical factors and age that modifies throughout life, together with lifestyles. Those are the most micro level, but then we have a meso level of social and community networks, and a macro level where perhaps I'm positioning at this moment during this presentation, where we see the living conditions and working conditions, unemployment, informality, as has been mentioned, are one of the challenges that we need to face in order to guarantee that basic right, which is health and security in work. We think in housing, nutrition, the neighborhood, the characteristics of urban sanitation, health services, food production, but the work that each one of us do is a determinant, and in the conditions that we carry out, it's also a basic determinant of health. And sometimes we forget this approach of occupational health or labor health, not present in public policies. And this reality of work and health is quite complex because it goes in both directions. In some books, sacred books, we see as a condemnation. You have to work to earn your living. These are the painting in the Sixtine Chapel from Michelangelo. As in fact, many times work can be considered a condemn or a curse, but not always is the case. Sometimes work can result in health, as Sorolla shows us in this wonderful painting, work, light, happiness, joy of this house in Valence, and working with the sail to go out fishing. So it has positive and negative effects. And health can also affect work. If I feel well, if I'm physically and mentally well, as Dr. Sepúlveda mentioned, I'm going to do a more productive work. Let's think on SDGs number 8. A decent work and a productive work, and health is a necessary condition. I don't know if it's sufficient, but necessary for that work to be productive. Now going to a more operational model and looking at working conditions and employment, those places, those equipment, those materials that have been mentioned in this opening words that have conditions how to deal with the pandemic from the health service structures. We also need to consider the employment conditions, salary, contract, sometimes classic occupational health. There's an excess of looking to working conditions, but we also need to look at the employment conditions in the scope of human resources, and we forget that that was also has opportunities of prevention and protection of health, the social protection, fair treatment, and that has to be considered in the enterprises. And that relationship of work and employment in terms of conditions, in a paper published a few months ago in the Scandinavian Journal of Work Environment Health, we have this conceptual map where employment conditions and working conditions, because are in its maximal expression in positive, we are talking about a decent work. when they are in very negative conditions, very poor in terms of contract, working hours, of complicated schedules that are endless, that allow me to organize life, and low salaries and inexistent social protection benefits, or the working conditions with dust, with unstable surfaces. We talk about informal employment, which is a counterpart, the opposite of decent work. And in the middle, we have different scales of precarious employment. Sometimes precarity can be a better situation than the informal situation, because in informal employment, there's no protection or any possibility of doing any intervention. Therefore, in this cartoon of a Spanish author, what a point in wearing a helmet, because my danger is to receive a kick in my ass. I don't know how long I'm going to have to work. This is a change of paradigm. So therefore, we need to introduce employment conditions in our approach and analysis of the workplace. And going to a more macro level, where we have the labor market, as we're going to hear later, the labor working relationships and productive structure, there we see the state. The state, which is an invention of modernity. It's a political concept, in Machiavelli, in his book, The Prince, he talked about state. And then Hobbes, with the grand Leviathan, where the state can play a negative role, but the modern evolution of the state from Europe and from the West, the look from the Americas and the East, but the state is a product that develops in the 16th and 17th century, and the crisis of feudalism, and with absolute monarchy, they try to establish an absolute power with a positive but also negative aspects. And the pandemic in Europe and the Black Death, a bubonic plague, the Black Plague, gave rise to a profound transformation of government mechanisms. And in the 18th and 19th century, with the American Revolution, that it was before the French colleagues, but the Statue of Liberty is a present of France given to the US for the help you received during the French Revolution. There's a fundamental transformation, and the modern state has some key elements to guarantee the hegemony of that power, and it's the use of strength and the monopoly of violence by the state, and develops an army, a diplomacy, and a bureaucracy. This is the context that I share. And behind this emergence of the state, the well-being state, that comes from this colleague, a professor in the Pompeu Fabra, facing the shortcomings of the state. They can compensate the relationship between capital and state and work through tax collection and social security and money transfers. What we're doing, I'm a public employee, it's a specimen transference through taxes. They pay me, which I hope is useful for all of you. And we remove from the market the decommodification to take out from the market some basic activities such as education or health, and in this case, a transfer in species, or in the case of pensions. This book from Thomas Piketty, Capital, shows in one of its wonderful graphs, this well-being starts when the states start collecting taxes and go from 10% in these 4 countries, US, UK, France, and Sweden, from 10% to collect, in some cases, with the, but this was maintained that the states in France and Sweden are managing 50% of their GDP. And that in the data from 2021, we see Colombia, Costa Rica, countries like Denmark that is managing 50% of their wealth. Spain, we are in 38%, in Colombia, 19-20%, Peru, Chile, here, member of 22%. And you can see this gradient, and this allows that the states can offer health services, education services, and other services such as pensions. Where does this come from? This amount of resources that the states collect in order to develop those services outside the market, at least at a level that can be accessible for the population. Well, most of it, in the case of Spain, 37% come from work, but also taxes, the physical person tax collection, or IRPF. This is income tax. It comes from work. It's or the social security contributions or society taxes. In that relations of capital and work, where the capital has that and generates that investment. Here is one of the key elements of the well-being and the possibility that they can offer health services, which is the focus topic of this webinar. In public health, which is public sanitation, and we could debate it maybe later. Public health is a contemporaneous institution. With the emergence of cities, we needed water, waste management, food safety in the modern state. With the emergence of the modern state and the definition of freedom of the liberal state, public health at that time had the fundamental mission of guaranteeing safety. And this is an activity of public administration, especially facing the epidemics, because the epidemics are disruptive and affect trade and normal activities, as we've seen in this COVID-19 pandemic. But with the emergence of the well-being state, where it's not only to guarantee safety of the citizens of that territory, where the state has a responsibility of guaranteeing the safe inhabitants and the citizens, and to guarantee that safety. Also, the well-being of the state has to look that this well-being occurs between 19 and 20. Public health at that moment added to their mission not only to guarantee safe food, clean air, but also make the reduction of inequalities, that in addition to have clean air and no pollutants, and food safety, and eliminate waste and drinking water in good conditions, that working conditions are adequate. In addition of guaranteeing that, we need to try that reaches all the population, not only someone who's more privileged. To reduce social inequality is a fundamental goal, together with the first one of guaranteeing safety and health and public health. And this scheme published in this comment that I'm sharing with you, public health is the hinge between the health system and primary care, hospitals, and the rest of component of the well-being state: education, dependence, environment, research, trade, transport, unemployment, pensions. If public health as a hinge between the health system and all the other elements of the well-being state, where we have the key of guaranteeing that well-being, that safety, and that reduction of inequalities. In this graph, when the ILO celebrated their 100 years, they how the growth of Social Security from before the ILO creation in 1919. The celebration was quite reduced because of the pandemic. The ILO is before the UN system and WHO and PAHO, who come from the Nation League, was celebrating their 100th anniversary. How the countries have been developing systems for social protection, also have to do with occupational injuries, guarantee the adequate care for people who suffer an accident and then occupational diseases. The unemployment insurance, so the percentage of countries that have some type of protection for unemployment is the one that has the lowest percentage of countries. And this is to protect people who, against their will, are unemployed, which is the main source of income. For most of sapiens, the most important source of income is our salary, our job, in addition to those systems of social protection. And to help us that if we lose our job because of we get ill or we are old and we cannot continue to work, salary is the most important source. This is a chart of how countries develop the Human Development Index, the social, political, and economic development, how the different systems of social security are developed in these ones before, who have higher. One of the reasons for human development is to put in place social protection systems in all their areas: maternity leave, pensions, invalidity, survivors, or unemployment. And the most recent one that have joined with more delay are those with low HDI. We need to have those systems for social protection surrounding employment. And these are distributed unevenly in different parts of the world. A decent work, which is the goal, and I'm finishing and this is the objective of the ILO, and is the main goal for these policies. Decent work uses social protection and security and the possibility of participation. Now it's included in the 2030 agenda as SDG 8 of decent work and economic growth, that balance between capital and work that the 2030 agenda also considers. The virtuosity of those two vectors that we need to get to some type of agreements to move ahead. And that goal of decent work rests in these ILO agreements, The most important ones are the C-155 in 1981. That was the basis for the European Directive of 89. Fortunately, Spain is now in the European Union in 1986, and we found the transposition of this agreement that has allowed us to accelerate our progress in relation to guarantee worker health and safety in Spain. Work can also be decent, healthy, and secure. So occupational health is going back to that metaphor of the hinge. And this is an editorial that was recently published. In occupational health is the hinge between the healthcare system, public health, and above all, the social protection system. In that space, we need to locate the specific activities of economy, hygiene, psychosociology, or safety that companies need to develop in order to improve those working conditions, those employment conditions that I mentioned before. Safety and health in work is a declaration in this ILO meeting of last year. We as members of the ILO have to follow. In summary, labor health has a singular mission of connecting public health policies with the social protection system, and public health sometimes doesn't consider those public health systems and consider security on the other hand, and to prevent the risks. Labor health has a significant contribution to the sustainability of the welfare state, facilitating a healthy and long life of people who work, making possible a productive and decent work. Thank you. Thank you, Dr. Fernandez, for your presentation. You have told us that work is a social determinant of health. People grow, work, and live. And there are a lot of forces that influence in these life conditions. They're present to be a determinant, not only in labor conditions, but also employment conditions. I would like to highlight that in 2021, the Ministers of Health, following a resolution, they created the intersectorial roundtable of fight against inequalities in order to promote the creation of a regional monitoring system with emphasis in reduction of health, social inequalities. And as you mentioned, roundtable is part of the exercise that we do to reach SDGs, specifically speaking of number 3, promoting healthy life and promoting well-being for everyone. And as you have mentioned, in SDG 8, to promote decent work and employment and economic growth, we can also indicate that these are important topics that affect the attraction and retention of staff. Well, working health is the situation of social, physical that workers find in their working places in order to promote measures to reduce the risk of diseases and accidents. Dear Dr. Benavides, we reiterate our thanks for your excellent lecture, and we invite you to remain in the room. At the end of the lectures, we will have a dialogue based on the questions generated, and maybe we can expand some of the comments that you gave at the beginning of your presentation. So we thank you very much for the space. Now, to analyze the health labor market, we welcome Dr. Pascal Cern. Dr. Pascal is an health economist with a PhD in economics from the University of Lausanne, Switzerland. with more than 15 years of experience at national and international level. He specialized in health systems and economic evaluation. He is coordinator of the Health Labor Market Unit, Department of Health Personnel, World Health Organization in Geneva, Switzerland. His main areas of responsibility include leading health labor market analysis, developing tools for health labor market analysis, and supporting countries in the development of health workforce plans. Go ahead, dear Dr. Pascal, you have the floor.
Thank you very much, Adira. Thank you very much to the Andean Health Organization for the invitation. So I will share my screen and hope that everything, yeah, I think it looks all right. So I'm very pleased to be part of that important seminar. And as Dr. Benavides highlighted the importance of worker health and safety. Now I will go more on health workers per se, because they are the one who plays a very important role to ensure the health of the workers in general. So there's an whole dynamic around the health workers that we have to understand to be sure that they can provide the quality of the care to the people that needed that to ensure really a maximum health benefit for the population. For this, one way to do that is to understand, I would say, the labor market, but it's the labor market for the health workers. So we call this the health labor market. And it's important to do an analysis of this health labor market in order of highlighting different elements. The first one is that when we do a health labor market analysis, it allows to have a better understanding of the health workforce. And this understanding is very important because that helps to better identify the key issues, some challenges around the health workforce. And this type of work is really not an end on its own, but rather a first step in a broader process in terms of development of health workforce plan, like planning for the health workforce, what is needed. So if we want to know well what is needed, we need to understand what we have, what are maybe some of the issues, and then based on this, we can have strategies, policies in order to reach the goals that we would like to have. And it is important to do this because challenges, there are many challenges around the health workforce worldwide, sometimes more acute in low and middle income countries. For instance, many countries are facing shortages or sometimes surpluses of health workers. But here, if there's a shortage of the health workers, that will also have an impact for the workers' health in general, so or in the population. So if there are not enough health workers, how can we ensure that good health is delivered through the health system to the entire population? Migration of health workers is also often an issue. And here it also relates to what was discussed before by Dr. Benevudo. For instance, if there are no decent working conditions for doctors, nurses, they might decide to migrate from the countries, leading to problems of provision of care in the countries that they are living. Maldistribution of health workers is also something often seen in many countries. In fact, in every country, usually there's always a higher density of health workers in the cities and much less health workers in remote and rural areas, which also leads to some serious issues in terms of equity, in terms of access to health care. Unemployment is also a problem in some countries. Doctors, nurses are trained, but then there are no budget to recruit and employ them. This is often even the case in some countries where there's a need of more health workers. So there's a decision to train more health workers. But then, unfortunately, once they are trained, there's no budget to recruit them. So sometimes they either become unemployed or they decide to migrate or even go for another occupation. Quality of education is another example of a serious challenge. Sometimes there are too many students or not enough faculty members. And as a result, the education cannot be of a high quality, which will also lead to serious issues in terms of the impact on the population health. Gender inequality is also a major problem within the health workforce. There's a pay gap that has been observed between men and women in the health workforce, and also although in the especially for nurses, but more and more for doctors, that the majority of health workers are women. The senior management posts there are mainly in most countries held by men. So another inequality issue that is important concerning the health workforce. And the last one, which I already started to discuss a little bit, is that mismatch between education capacities and employment. That is the fact that we train health workers, but then those health workers cannot be recruited, or sometimes there's a mismatch between the field in which they are recruited, they are trained, and the open positions that are not matched with the profile of the health workers that were trained. So on the one hand, we have people with certain qualifications that are trained and for which there are no vacancies, no possibilities to work, and some vacant posts for which no one is available to fill that position. So really a lot of issues that have a lot of consequences. And this is why it's important to understand that labor market for the health workforce, because if we can solve those health workforce issues, that results in a better access for the population to a quality health services, and will help countries to move towards universal health coverage and the Sustainable Development Goal number 3. So it is really important for countries to identify the key health workforce challenges, to understand on this basis to provide some policy recommendation, because the health worker is really an essential element in the health system. It's really the essential, the most important one. But at the same time, in many countries, it's in a way the weakest link in the health system. And because of that, the health system cannot perform well. And hence the importance to identify the issues on which recommendation can be done. This health labor market, this health workforce, when we look at it, it's a very complex element, because if we look at what is the profile of the health workforce today in Peru, in Spain, in Switzerland, in the US, it's really, and I like this quotation, it's today's profile of the workforce is the result of many decisions, big and small, taken by many different persons or institutions over the past 40 years or more. And I think this was a quote by Tom Hall, who was very famous in health workforce planning and researcher. And I think that captures very well the complexity of the health workforce, the profile, because you have a lot of different actors. For instance, if we looked at that labor market, how it is shaped by the different decisions. So we have ministries. Of course, we are thinking of the Ministry of Health. Of course, it plays an important role, but not only the Ministry of Health, also the Ministry of Education, responsible for training health workers, but also the Ministry of Employment, who plays an important role sometimes in terms of the recruitment. The Ministry of Finance, of course, because money is always an important element. Sometimes Ministry of Foreign Affairs or Ministry of Trade, because they are involved sometimes in agreement to facilitate the movement of workers in general, but including health workers. So also that will have an impact on the dynamic. Employers, of course, like the hospital, private or public, private sector plays an increasing important role in many countries, and it's important to get this private sector in the picture when we want to do an analysis of the labor market for the health sector, and the regulatory bodies that have a power by influencing, for instance, the number of new students or setting criteria for specialization, and of course each person, individuals that make their own decision, for instance, and I will come back to this on what if they want to study medicine or law, or want to work on the private sector and the public sector. So all of that is really a complex dynamic. So we try to reflect this dynamics, to express it in a simple framework, to show a little bit how to monitor, how we can have element to analyze and better understand the health workforce. And if we do that, what are the key points to which we need to look at? So this is, and the good news, it's in Spanish, so you will understand that framework better than I do, because personally my Spanish is not very good. So this is what WHO has developed, the health labor market framework. And if we start on the left with the education sector, so here already there's some thinking or analysis that are important to do in terms of understanding well what makes students either to go in the health or health studies or not, and also if it is in countries, private universities, for instance, private medical schools, that are playing also an important role. It's really some of the elements regarding the education sector that are key to capture if we want to have a good understanding, and then to see also what are the implications. For instance, it has been observed in some countries, notably in India, in a state in the south of India called Kerala, a lot of private schools for nursing have appeared, and a lot of the students that study there, their aim then is to work outside India to go for other countries. So in a way, there's a demand for studies to go afterwards abroad. For medical school in Brazil, for instance, there's also a large number of private medical schools, and then raises some issues in terms of access to those schools, in terms of what are the fees, if it's much more than the public sector. So in terms of access, it's already a challenge. And then also in terms of the curricula, will it really reflect the needs of the country? So this type of issues is similar in other countries. Then if we move to the right, the next step is once people are qualified as a health worker. So usually I would say the main group of people qualified as health workers in the countries are trained locally, but there's also more and more this issue of migration, either in terms of immigration or leave the country if they don't find a job, or if they think they can earn better, or maybe to also have some better professional perspective in another country. Or they can attract medical doctors or nurses from other countries. And this is a little bit the situation we see now in Europe or US, that are more attracting doctors and nurses from other countries. And countries, there's a lot of discussion now in some African countries, not only in Ghana, Zimbabwe, Nigeria, where a lot of doctors, nurses are leaving those countries to go to Europe or to the US. And here also the next boxes are interesting. Is even if you qualified as health workers, it doesn't mean that if you stay in your country that you will automatically have a job in the health sector. What has been observed is that some health workers, of course, the majority have a job, but some are unemployed, or some have decided to leave the labor market. And the fact that some are unemployed raises some important questions, especially in countries where there's important need of health workers. It has been observed in some African countries where they already have a low density of health workers, that not only you have a low density of health workers, but on top of that, you have unemployed doctors and nurses, which may look as a paradox, but by analyzing that labor market, then we can understand why they are unemployed. And often it's related to the fact that the budget to recruit those health workers are not important enough for a recruitment. And this issue is particularly important now with the I would say the economic tension observed since COVID, and that really a lot of countries are now facing in Africa some challenges in terms of maintaining their public spending or to reimburse the debt, and that have some issues in terms of the recruitment of the health workers. Recently, a country like Ghana, who wanted really to increase the number of nurses, train additional nurses, but unfortunately, given the economic situation, was then not able to recruit all of them. And as a result, many are unemployed. And then Ghana, but also other countries, are trying to negotiate some bilateral agreement with other countries in Europe to facilitate the migration of those health workers. So you get this dynamic. And even if you work as a you might work as I was mentioning in the health sector as the majority, but what also observe is that they might work, doctors might work, or nurses or other health occupations might be in other sectors as well. And often it is people that don't find a job or who migrate, and then they cannot work as a doctor in the country that they migrated to because of the recognition of the diploma. And you always have stories of a doctor who is a taxi driver. So by having those different elements followed and well analyzed, then we can really understand what type of policy can be developed in order to address those challenges that have been identified. Because often we don't have too much information on the health workforce in the country, or at least not the one we would like to have. So that's why it's important to go more in depth and having a better understanding. So this is really I would say the intuitive framework to understand the labor market for the health workers. And in WHO, to that end, we developed a health labor market guidebook to facilitate that type of work, and also to systematize it, standardize it. And here, this is the guidebook, which is the link is below if you want to consult it, and is composed of 4 sections. The first one is really providing some of the conceptual and practical element regarding health labor market analysis. The section 2 is more about the core elements, and this is based on the framework I presented. The third one is related to some cross-cutting issues. There are some issues that are all the way across the labor market, notably in terms of gender, if it's for the education, the employment. So gender is really a cross-cutting issue, as well as the issue of the public-private sector, be it in the education or in terms of employers as well. In some countries, like in India, the majority of health workers are working in the private sector. So that raises issue of if a country does planning, but at the same time, the majority of the health workers are working in the private sector. So how do we address this? And it's really something important to consider. And finally, section 4, it's how we can use the evidence that result from this type of analysis and then to translate that to policy. So it's really the approach that has been done. And there's been health labor market analysis in many countries already. I just wanted to illustrate one example in India, in the state of Chhattisgarh. The idea was to ask the Minister of Health and key stakeholders what are the key issues you are facing, and based on that to apply the framework and to come with some recommendation. And for them, the key policy issues was to know if the productions of health workers is sufficient to meet current demand, and how the recruitment and deployment process can be improved. So some of the results in terms of evidence that were found through the analysis, this is just one example, is the first one is that in fact there was a lack of absorption capacity for the health workforce. In other words, while on the one hand, over the past 18 years in that state, there were around 4,000 doctors that were trained, produced, only 900 were recruited. So here you say it's really the issue of we train quite a big number, but only very few are recruited. And some of the main reason for this gap between the number of trained doctors and the number of recruited doctors is that there were irregular recruitment drives, meaning that sometimes there was 1 year a recruitment and then nothing for 2 years, and then again something after 3-4 years. So of course, but at the same time, doctors graduate on a yearly basis. So if they cannot, maybe they don't want to wait 2 years before, so they go somewhere else. And on top of that, even when there was a recruitment, between the moment the person applied for the job until the person is really at the place doing the job, there's also another big gap that has been identified, because that recruitment process is very bureaucratic, and it takes a long time. And another element is, especially, and again, is this issue of the maldistribution between the rural and the remote area, that in the remote area, people don't want to go so much. And in that state, there was really a lack of appropriate incentives for serving in those places. And as a result, the vacancy rate was very high. And you can see that in some of the districts, it's well above 50%, that the vacancy rates, because they cannot attract, although they have positions. So as a result of that, when we go in terms of the policy, one key decision that was made was the creation of a health workforce technical group comprised of key stakeholders that really was part of the labor market analysis, and after facilitating also the recommendation to implement the recommendation and to follow up. And this, when the evidence was presented to the people from the Ministry of Health, so it led to an additional recruitment of medical officers by addressing some of that bureaucratic process. and also to train additional nurses to be able to manage what they call health and wellness centers that are like small primary healthcare centers in remote and rural areas in order to decrease those vacancies. So you can really see that it has led to a change in this country, but also in other countries. So now in South America, also there are different issues. And not so long ago in March, we had PAHO organized a meeting in Bogota to discuss the impact of COVID and on the health workforce, what would be some of the priorities, and based on that and other elements, PAHO, but also the Andean Health Organization, come in terms of the health workforce for some key areas to work on health workforce policies and planning, on regulation of training and professional practice, on interprofessional teams and first level of care, on workforce capacity building for public health emergencies, and that's really related to COVID, and this issue of decent work and physical and mental health protection of health workers. But it's true for all workers, not only health, but COVID really highlighted the burden for the health workers of COVID. So, and for this, if we go more in depth to move towards working on those issues, having a health labor market approach will also be very helpful. Finally, in terms of conclusion, just to say that health labor market is key to identify and gain a better understanding of the health workforce challenges. And it's not an end on its own. It should really be part of a process, part of a planning, of a strategy, of a policy. And that's the best way to move forward and to ensure that the work, not only the workers, but population is healthy. I will stop here and thank you very much.
Thank you very much, dear Dr. Pascal. Very valuable presentation. You have pointed out the profile of health staff is a result of many decisions. You also share the conditions that should be fulfilled in the example with health personnel with regards to migration. And also you mentioned another factor, which is the quality of education. And I would also like to find the feminization of the health workforce that is present worldwide, and other situations that you mentioned, the disparity in between employment and education. In addition, health workers has a direct impact on productivity, satisfaction, and well-being. Therefore, we need to measure and evaluate health from the labor market that takes into consideration the difference between countries and sectors. Something else that I would like to highlight is that health labor market is influenced by offer and supply, the working conditions, and salaries. And this that I just you mentioned in detail was reflected in the study made in 2022 by the Andean Health of Human Resources with our institution, with a South American PAHO office, looking at the conditions that determine the selection of health recruitments in areas of low care, where 2,207 health workers of the Andean countries participated. Among the variables that we evaluated were part of the exercise made in this presentation, were the stakeholders who make decisions for attraction and retention, factors such as origin, personal values, family and community aspects, work and living conditions, professional aspects, among others, situations, very important as reflection method. So, dear Dr. Pascal, we reiterate our thanks for your excellent lecture. We invite you to remain in the room. After the active break, we will conduct a dialogue based on the questions. Thank you very much for your participation, and thank you so much. After these moments of learning and knowledge exchange, it is essential to take some time to relax and start a mini physical exercise session. Horace Kono encourages the well-being of those who accompany us in this virtual session, and in the next few minutes, we will exercise with an active pose to stay healthy, combat stress, reduce work fatigue, and keep muscles flexible and healthy. So please go ahead with the active pose. There will be no interpretation during the active pose.
Buenos días, buenas tardes, desde cualquier parte del mundo, donde quiera que te encuentres, bienvenidos a realizar esta actividad saludable. Hoy, a través del Organismo Andino de Salud, Convenio Hipólito Unanue, los invitamos a realizar esta actividad saludable. Así que toma tu sillita y nos vamos a sentar hoy más o menos al borde del asiento. Vamos a fortalecer el abdomen, la zona lumbar y las piernas. Así que saca pecho, tus dos manos toman o los apoyabrazos o el asiento mismo, lo que quieras. Cuando estés listo, sonríes, perfecto, y con una sonrisa suba las dos piernas, ya, suba las dos piernas. Así nos vamos a quedar hasta las 8 de la noche y vamos a ver cómo se fortalece todo. 10, 9, 8, 7, 6, resista, 5, 4, 3, 2, 1, baje las piernas, descanse. Ya se empieza a sentir este calentamiento. Ejercicio número 2. Agarra su silla, saca pecho, sonríe, suba las piernas. Perfecto. Y ahora pedalee, pedalee, rápido, veloz. Usted está encima de la bicicleta. Perfecto, viajando por el mundo en bicicleta, en Bolivia, en Chile, en Colombia, en Ecuador, en Perú, en Venezuela. Hoy pedaleando juntos para lograr favorecer nuestro estado de salud. 5, 4, 3, 2, 1 y descanso. Ahí ya se va sintiendo en piernas, abdomen, claro que sí. Bueno, tercer ejercicio. Quiero que agarres tu sillita, apoyabrazos o el asiento mismo. Perfecto, saco pecho, sonrisa que no puede faltar, suba las piernas, perfecto. Cuente 10, 9, 8, 7, 6, 5, 4, 3, 2, 1 y ahora pedaleo. Mezclé los dos ejercicios, perfecto. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. No te rindas, baja las piernas. Ahí se va sintiendo. Esta actividad la puedes hacer desde cualquier lugar. Los que están trabajando, estudiando, bienvenidos siempre desde el Organismo Andino de Salud. Así que agarre su silla, perfecto, suba las piernas y mire, vamos a marcar el abdomen, abajo y arriba. Vamos a hacer 650 de esas, si se puede. Vamos, 10, 9, respire, 8, 7, 6, 5, 4, 3, 2, 1, bajo las piernas. Ay, cómo se siente. Vamos a mezclar los tres ejercicios. Entonces recuerda, sostenemos, luego pedaleamos y luego dejamos las piernas en un balanceo arriba y abajo. Entonces agarro, saco pecho, actitud, sonrisa, prepare la mente y ahí sí el cuerpo. Nos fuimos arriba. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, que sigue, pedale, rápido, veloz, ágil. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, arriba y abajo, nos fuimos. 10, 9, respiro, 8, 7, 6, 5, 4, 3, 2, 1, baje las piernas, ay, descanse. ¿Cómo se está sintiendo? Se siente la presión en las piernas, en el abdomen, espalda. Subimos la temperatura corporal en nuestra pausa activa. desde el horas cono. Bueno, nos fuimos a agregar otro movimiento porque ustedes son valientes, guerreros, fuertes, guerreras, invencibles, eso es. Bueno, agarre por favor su silla, apoyabrazos o el asiento mismo. Mire el siguiente ejercicio, suba las piernas, perfecto. Y ahí donde está el balanceo solo de las rodillas al frente y atrás. Respiro, perfecto. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Bajo piernas, descanso. Tomo aire si se puede. Y llegó el momento de unir los 4 ejercicios, ¿listo? Mentalícese, tome aire, agárrese, sonría y no se rinda. Yo creo en usted. Agarro, subo piernas, perfecto. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. ¿Qué sigue? Pedalee, muy bien, rápido, veloz. Energía, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Arriba y abajo. Respirando, 10, 9, 8, si se puede, 7, 6, 5, 4, 3, 2, 1, balancee, mire, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1 y descanse. Ahí se va sintiendo la energía aquí en todo el organismo andino de salud. Yo veré que estamos marcando la chocolatina, fortaleciendo la espalda, las piernas. La gente de Bolivia, de Chile, de Colombia, de Ecuador, de Perú, Venezuela son los más fitness de todo el organismo andino de salud. Perfecto. Bueno, último ejercicio. Vamos a agregar el último. Mire, suba la pierna derecha. Perfecto. Cuando la tengas bien arriba, estírala un poquito y regálame 10 círculos con la pierna derecha. Mire, 10, 9, 8, 7, 6, 5, 4, 3, 2.
Perdón, tenía el micrófono cerrado. Sí, perdonen. Bueno, para iniciar el diálogo y
To begin this dialogue and consider the valuable time shared, our dear Speaker Fernando, before you leave the room, could you leave us a final message about this valuable meeting that we had today? Go ahead, Dr. Fernando.
¿Tiene su micrófono cerrado? Ahora sí.
Go ahead, please.
Disculpa, no he oído tu
My apologies, I
estaba
couldn't
recogiendo, es muy tarde.
listen to your message.
Si puedes repetir, por favor.
Sí,
Yes, I was saying that we have shared some of the questions, and because I know that you are running out of time, could you please give us a comments about the questions and a final message before you leave the room?
Gracias por la comprensión.
Thank you for your understanding.
Placer estar con
It's
vosotros
been
y
a
la
pleasure to be with you, and the question that they sent me that about what I've shared with you, I've already replied them. But as a final message, I think that the health sector needs an intense occupational health. Dr. Pascal Cern clearly stated, if we want to attract and retain health professionals, and not only physicians, nurses are also important, nurse auxiliaries also. Every worker from the health sector needs a labor health, considering the working conditions, but also the employment conditions, to promote participation from the autonomy that physicians and nurses have to facilitate family reconciliation and personal life. These are key elements that the care health system has to do for their workers if we want to retain them in addition to attract them. Otherwise, the perspective, as WHO has already stated, that we will have a shortage of millions of health workers throughout the world. And there the rich countries have advantage. And as Pascal mentioned, they should sign agreements with low-income countries so they don't attract the health staff. There are many vectors. This is a global market. The nurses trained in India ended up coming to the UK, and we need to try to stop that. Otherwise, those countries will have with an aging that is the most important problem, the chronicity that they will have to deal. I think that the challenges are large, and health workers is important in attracting and retaining health personnel. Thank you very much, Dr. Fernando. I fully coincide, and I will only add as a key issue about the working conditions, I will add mental health. Consider that the pandemic hit hard, and that burden and that invisible toll that is producing in those working in health. From Diana Health Organization, we thank you again, and we hope to have you in another phase. So thank you very much. Thank you. Morning. Now we will continue with the discussion with Dr. Pascal, who's still with us. So Dr. Pascal, could you activate your video, please? Yeah. Thank you. The questions, we have many questions and comments. I had several questions that I have shared with you. I would like to read them, and then I will send you the questions. There are some questions that go directly for Dr. Fernando. We were exactly what is the investment recommended for retention and attraction of health workers, and he responded. And the other question that I share is what measures can be taken to improve the occupational health of the medical staff. And he commented that in each hospital there's a health labor service, which is a guarantee, and there's a lot of margin for action, such as facilitating family reconciliation and professional autonomy. And he left this comment in the internal chat, and we thank him for his participation. Well, Dr. Pascal, we will start with your Q&A. I will mention what results were obtained with the implementation of policies on health labor market in the state of India. Could you mention? And also, I would like to ask you another question. Do you know of any mechanisms in the European Union that facilitate the recognition of professional titles, health staff for working and for their performance?
Thank you very much, Yadira. I'm still recovering from the healthy break. My legs are painful, and it's a very good. I never thought we can do so much sport with the chair. So it's a very nice way to stay fit. Regarding the first questions in terms of the policy result of the health labor market in India, in the state of Chhattisgarh, there the labor market analysis really allowed to identify some of the key challenges, and in terms of the difficulties to recruit, came with some suggestions to improve the recruitment process and to provide more incentives. what was successful is not only to make recommendation, because in many cases recommendations are made, but is that we did during all the process of the labor market analysis, there was that technical working group, health workers technical working group, that was established, that is composed from key stakeholders, Ministry of Health, medical schools, Ministry of Education, and by having them, there's an ownership process that started. So they help us to identify the issues. We discussed the solution with them, and then there were our first advocacy people to put in place those recommendations. And thanks to this, we saw the positive impact of the health labor market in the state of Chhattisgarh, because there's a timeline. It's not one day after we finish the analysis that the measures are taken. It takes time. It takes 1 year or more. But what is important is to put a process in place, and that's really key for the policy implementation success. Regarding the second element, in the EU, with the recognition of professional titles, so there is such a mechanism within the EU. That is, if a doctor from Spain would like to work in Germany, it's recognized. The doctor, the nurse can go and work. Sometimes one of the challenges is the language. So because there are some exams to be sure that the level of comprehension and the ability to speak the language should be there. And that resulted, when that was adopted, in a lot of migration within the EU. For instance, a lot of doctors from Romania started to work in France. And also, it's not only migration of medical or nurses that took place, but also of students. That was also interesting, and people didn't think of that in the beginning, because, for instance, some countries, especially for medical studies, they try to limit the number of medical students. So it's very limited. It's very hard to get a seat and to study. So what many, for instance, also French students that were not accepted in medical school in France, they went to Romania and studied there. And after the studies, came back to France because it's authorized. The same for veterinaries. It's very limited number of seats in France. So a lot of French students went to Belgium. They studied in Belgium, came back in France. So it creates an all kind of new dynamics, and sometimes we see the dynamics once it's taking place. I think a lot of those things were not anticipated with the mutual recognition of title, which the idea is to facilitate the movement of people, but in an equitable way, and in the case sometimes it created some inequities. So then other policies were put in place to address this.
Así es. Sería incluso... Perdone, doctor Pascal, creo que lo interrumpí.
No, I think there's no translation now. I don't know, but I finished what I wanted
ya.
to say.
Bueno, le quería comentar, perdone.
Okay, I just wanted to comment that it would be interesting to learn about the progress made in the implementation of this policy in India, and that would also be useful for us as an example or a review to see if we can use some of that significant experience for the Andean region. And for what you mentioned about migration and that dynamic in the EU, in the Andean region, we have the same migration in countries and between countries. However, there is no mechanisms that in the committee, perhaps we're looking to a way to facilitate, considering that the mechanism for retention of health staff is also uphill. So I think that we need to do some progress in that regard. So from that dialogue that we have, I have other questions. I'm not going to abuse your time, but I would like to ask you 3 more questions. And I think that we can move ahead. So the same question for Dr. Benavides. What is the investment on GDP recommended for protection and retention and support of human resources? What is the percentage of GDP of the investment? The other question, what successful strategies of mental health protection of human resources can be highlighted in the region? And if you know some, would you like to share that has to do with retention? And what are the most demanded skills in the healthcare labor market? I think that you have 3 interesting questions, Dr.
Okay, thank you very much. They're indeed very interesting and important question. The first one regarding what should be the GDP expenditure, that's a question that economists love to ask, and it's difficult to come with one specific percentage. Because what we observe, you have some countries that spends more than 10% of their GDP on health in general, not health workers, and some maybe 3%. Of course, the more you spend, it is expected that the better your health system will be, the better your health workforce. But it doesn't mean always that money is well spent. So we have some countries that may spend less on GDP, but spend it better. So there is no international recommendation regarding this. What some countries have done in Africa, and this is called the Abuja Declaration, is that in terms of the public expenditure, in terms of the budget, it was recommended that 15% of public expenditure should be on health. And that was many years ago, and unfortunately, not many countries have reached this target in Africa. So that's the other challenge. Even if you agree on the target, many countries might not reach it, and that leads to other set of problems. But what is sure is that also it's not only what is the percentage of GDP as such that is spent on health, but what is the share of public spending and private spending, because if it's a big part of GDP, but it's only private spending, that is people paying out of their pocket, that might not be a good spending because that will increase inequalities. So we need to understand here the composition of that spending. And what has been trying is really more in terms of public spending, what should be the public spending on health. And that's why the African countries came with the Abuja Declaration of 15%. For the other questions in terms of policies for mental health, or how to improve
Exacto.
retention. Of course, with the COVID crisis, it highlighted this issue of the mental health, and it relates to the decent work condition, the workload. So what we learn from the experience is that it is important to have a set of different policies. There's usually not one single policy that will address all the challenges of the mental health and the retention. But to improve retention, there are policies related to the education, so how you train people to prepare them in advance to face some situation. You have policies regarding regulation that may facilitate collaboration among different types of health workers, especially in times of crisis, or to give flexibility for additional recruitment to avoid an overwork of the health workers. You have also, of course, financial incentives. People, if they have to work more, if there's a high burden, so to compensate, and also to be sure that they don't have to work too many hours, that they have the proper equipment, that they don't face stress because of a disease and they don't have the proper equipment. So there's a whole set of policies that should be put in place. And those policies are important to have all of them together rather than only one of them. So that's a little bit, I would say, even beyond the issue of COVID, the lesson that we learn, especially to improve retention in remote and rural areas, is we need that different set of policies in education, regulation, financial incentive, even in terms of professional career, and sometimes it's even for the family, also to be sure that the family is supported. So it's something broad. Regarding the last questions, in terms of the skills, what we observe is that in terms of forecast, it's expected that more health workers are needed in high-income countries because of population aging. Also, already there are shortages in many low and middle-income countries, so there's a need of additional workers, so health workers. So there's already this clear point that the health sector will continue to be a very attractive sector. It's also there were some studies to anticipate which sector will be the most affected by all the technology, the change. So of course, there's a lot of new technology in the health sector, but at the same time, it's also a sector where the human contact is very important, and hence people will be needed. So I would say it's difficult to say exactly which skills, which profession will be in very high demand, but health workers in general, their skills will be needed in the future. That's compared to other professions that might be, now we're talking about a lot of jobs being replaced by artificial intelligence. So I think for the health sector, with patients, the interactions will still be very important.
Yes, tienen mucha razón. Bueno, y ya tenemos también
You're quite right. And we have this proposal for digital health. We don't have time to discuss it. However, we thank for all the questions. We weren't able to respond all. We have received many questions, but to close this space of Q&A, I will ask you to leave us a final message in 1 minute.
Okay, but for me, what is important is if we can change the perceptions of health workers, in the sense that in many cases it's considered as an expenditure. We talk about what is the expenditure for the health workforce, and I think we should really consider more as an investment. We invest in the health workers in order to improve the health of the people. So by having more and better health workers, it has a return on investment through the improvement of the health of the population. And I think that's an important message to convey, that we should not see as the health workers, to have more health workers, as just as a cost issue, but we should see it as an investment opportunity.
Así es.
Yes, indeed. Thank you very much, Dr. Pascal, for your excellent presentation today. And also we thank Dr. Fernando Benavides, who is not in the room. We publicly acknowledge his participation. We also thank all participants that week after week are with us, the Horas Konu team, and to all the people that make possible this space. Thanks to the commitment with Andean integration and Latin American integration and world integration. Well, to close, Dr. Marisela Malki, on behalf of the Andean Health Organization, Hipólito Unanue Green. Go ahead, Dr. Malki. Thank you, Yadira. Well, I will start by thanking the excellent presentations, both by Dr. Benavides as Dr. Pascal, turn in this important topic of human resources in health. The pandemic has demonstrated that they are fundamental pillar in the health system. We have seen the first line of attack to deal with this public health problem that shocked the world. And it is perhaps in this situation that gives us the opportunity to continue talking about this issue, because the health workers are an important stakeholder in the system. We have heard very carefully in this webinar number 171 in health work labor market, that work is a basic determinant of health, and that what the state should offer to the health worker should be acknowledged and considered as an investment and not as cost or expenditure, as Dr. Pascal just told us. And that we should push that virtuous circle, because if we invest more in improving the working conditions, the employment conditions, we're going to have workers with better health that are going to work better and more health, first for them, but this will also improve the health of the population, which is what we want at the end of the day. It's going to lead us to socioeconomic development that we all want to go on that path. Health, as it has been already mentioned, requires occupational health. Perhaps each hospital should have an office but it's important to start considering it because after the situation that we have suffered in different parts of the world, we need to start thinking in innovative strategies, attract and retain well health workers, and avoid those inefficient distributions that to look at the deficit and the surplus on the same side, where there's a greater number of those needed or migration, that we also need to consider of more importance in the quality of education and the relationship between the undergraduate and graduate training to deal with the problems of each country. And then the gender issue has been in the number of health workers, the percentage is larger of women. And I think it's been very clear in what that for the Andean Health Organization, we have been considering this topic for many years now. Since 1973, we start dealing with this issue. We're interested, we care to have a decent work, a safe work with protection, with rights that guarantee the health of the health worker. And if we consider as a social protection system. Once again, thank you for these brilliant speakers and to each one of the people that are join us every Thursday on this webinar that since 2020, in May, the Andean Health Organization is promoting and organizing. And to thank Yadira and the entire team of the Horas made this webinar possible, and to invite you for our next webinar the next week, an extraordinary one on Tuesday, May 9. We're going to talk about the situation of the strategies in human traffic in the Andean region. Tuesday, May 9 at 11 a.m. Once again, thank you very much and see you next week. Thank you.